Welcome, everyone. The webcast will begin in 2 minutes. The webcast will begin in 1 minute. So welcome everyone to the Leukemia and Lymphoma Society of Canada's webcast, Understanding Myeloproliferative Neoplasms, Diagnosis, Treatment, and Follow-up Care. In this webcast, Dr. Lynda Foltz will review the different types of MPNs, diagnosis, treatment options, and aspects of follow-up care. Let me introduce myself. My name is Sonia Muto, and I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments in the question box of your GoToWebinar panel throughout the presentation. I will read some of your questions out loud at the end of the presentation during the question and answer period. The conference will also be recorded, so therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that might be helpful to you or someone you know. Just going to change my slide. I appear to have lost control of the slides. Oh, too far. Just give me a moment. All right, so at the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by blood cancer cope with anxiety and isolation during these times. Please do not hesitate to contact a community services manager in your area. As part of MPN Awareness Week, I invite you to visit bloodcancers.ca to read testimonials, listen to podcasts, and download our new information sheets on the different types of myeloproliferative neoplasms. One more slide. Dr. Foltz, if you can just change the slide for me. Doesn't seem to be responding on my end. Dr. Foltz, can you hear me? I apologize. I think we're having some technical issues. So we'll just give Dr. Foltz a few moments and she'll be able to log in. I apologize, everyone. We're just having some technical issues. So we'll give Dr. Foltz a few moments to be able to log back in. If anyone is just joining us, we're just going to need a few moments. We are experiencing technical issues with Dr. Foltz, so we'll give her a few moments to log back in.
Okay, sorry about that. I think I was
okay.
there was some local issues with my internet. My apologies. It was on my
Not
end.
a problem.
I'm hoping it's up again, but my apologies in advance if we have any future problems. I'm working on a backup plan as we're doing this.
Not a problem. You could also turning off our webcam sometimes helps. So if we see it's happening again, we'll do that.
Sure. Thank you.
Not a problem. Excellent. I think I have control still. Perfect. So there we go. There we go. So welcome back. So on our website, along with MPN Awareness Week information, you can find the recordings of all our previous webcasts. You can simply click on a webcast that is of interest to you and watch it at any time. We'd also invite you to subscribe and listen to our podcast series. It's called The Blood Cancer Experience, and you can learn more about treatment and research and hear stories from people affected by blood cancer. It is available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your favorite podcasts. Our peer support program is a supportive service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by blood cancer and share similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis. It can be a useful program these days to counter the effects of isolation. We would also like to highlight an important collaboration with the Canadian MPN Network, working together for the entire Canadian MPN community by providing support groups and patient education in both English and French. So it is now my pleasure to introduce our speaker today, Dr. Lynda Foltz. Dr. Foltz completed medical school, internal medicine residency training, and hematology subspecialty fellowship at UBC. She joined the Division of Hematology at St. Paul's Hospital in Vancouver in 2007. She's a clinical professor in the UBC Division of Hematology and was head of the St. Paul's Hospital Division of Hematology from 2013 to 2018. Her area of special interest is myeloproliferative neoplasms. She's a principal investigator for MPN clinical trials and is a founding and executive member of the Canadian MPN Group. Over to you, Dr. Foltz.
Hello. Well, thank you very much, and thank you for inviting me to speak today. I'm keeping my fingers crossed that our technical difficulties are behind us. All right, so I'm going to be speaking today on myeloproliferative neoplasms, and when the myeloproliferative neoplasms include three related blood conditions: essential thrombocythemia, polycythemia vera, and myelofibrosis. So essential thrombocythemia, patients primarily have elevation in platelet count, with polycythemia vera, primarily high hemoglobin or red blood cells, but can also have elevated white blood cells and platelets. And with myelofibrosis, patients primarily have fibrosis or scarring of the bone marrow, often have anemia or low hemoglobin, and the other blood counts can be high or low. Now, these blood conditions are closely related in that, so most people with ET and PV, the disease remains stable and does not progress over time. But in about 20% of people with PV and ET, over a period of approximately 20 years, there can be progression to myelofibrosis. So we would call this post-ET or post-PV myelofibrosis. Other people can just start out with myelofibrosis, which would be primary myelofibrosis occurring as the initial disease. With these conditions, there is a risk of progression to AML or acute myeloid leukemia. That risk is highest with myelofibrosis and quite small with ET or PV. And when people with ET or PV do progress, it's usually through an intermediate stage of myelofibrosis. These blood conditions are also related because of all of these blood conditions share activation of a specific signaling pathway in the cells. So this is the diagram of the cell. This is the cell membrane, and this is outside and inside the cell. And all people with MPN have increased activation of what we call the JAK2 signaling pathway. And this JAK2 signaling pathway, when it's active, stimulates the blood cells to grow and divide. So it leads to the increased production of the blood cells. Most people with MPN have a mutation. The most common mutation is a mutation in this JAK2 protein called the JAK2 V617F gene mutation. And this is not something you're born with. It's something that can be acquired later in life as the triggering factor for developing the myeloproliferative neoplasm. And we see this mutation in up to 97% of people with polycythemia vera and about half of people with ET and with primary myelofibrosis. So this JAK2 signaling activation and mutation is a clear link between these disorders. In people who don't have the JAK2 mutation, there is activation of the same signaling pathway by other mechanisms. So the next most common mutation that's seen is a mutation in what we call CALR or calreticulin. So this protein is supposed to be in a completely different location in the cell, but when it becomes mutated, it can bind to this receptor and lead to activation of the signaling pathway. And it may also cause activation by other mechanisms as well. Finally, other patients can have a mutation in MPL or MPL, which is this receptor here, also leading to activation. So those are the three main driver mutations that cause JAK2 signaling activation in the myeloproliferative neoplasms. And so in polycythemia vera, it's almost exclusively this JAK2 mutations, whereas in ET, about 50 to 60% of people have the JAK2 mutation, 35 the CALR, and a smaller percentage to the MPL. And similarly, myelofibrosis, half JAK2, and then a smaller percentage for others. There is a subgroup here of people who we call triple negative, who don't have any of these mutations, but do have activation of this JAK2 pathway by other mechanisms. Okay, I'm going to talk about ET, PV, and myelofibrosis I'll try to cover an overview of all of these in the talk, but I'll start with essential thrombocythemia. Okay, so essential thrombocythemia, this is where people have high platelet count due to the abnormality of essential thrombocythemia in the bone marrow. And the annual incidence is about 2.5 cases per 100,000 population. The prevalence is much higher because people often do well with ET for a long period of time, so it's up to 24 to 25 per 100,000. Women more commonly affected by men. Median age of diagnosis is 60, but a significant percentage of people are younger, with up to 20% being diagnosed under the age of 40. We wouldn't see it in children, but we can see it, very unusual in children, but we can see in young adults. This is how I think of the clinical manifestations of ET. So the three main areas that we think of with ET, the first is symptoms. So many people can have symptoms related to having ET. There is this risk that I talked about of progression to myelofibrosis and rarely to leukemia. But the biggest issue with ET is the increased risk of thrombosis, and this can be in both the arteries or the veins, and an increased risk of bleeding. And most of our treatments for ET are targeted at trying to reduce this risk of thrombosis and bleeding. So there are a wide range of symptoms that we can see with ET. Some patients, though, can be asymptomatic with no symptoms at all, and it's just picked up on routine laboratory testing. Fatigue is really common, so a lot of people experiencing fatigue. Many people can have headaches. There can be enlargement of the spleen, which sits over on the left-hand side under the ribs. If it's just mild, most people wouldn't notice, but if it becomes quite large, then it can be uncomfortable, or it can cause people to feel full sooner because it pushes on the spleen. So sometimes people find difficult, or pushes on the stomach. So sometimes people have difficulty eating large meals. Erythromelalgia is a very unique symptom that there's a picture of an extreme case here, but what people notice are redness and burning of the hands or the feet. Often it just involves the fingers and sometimes just the fingertips or the toes. It would be less common for it to involve the whole hand as in this picture, but it's a very unique symptom that we can see in ET and sometimes in PV. And then itch can definitely be a factor. This is an itch without a specific skin rash, and it is often triggered by exposure to water, such as a bath, shower, or swimming pool. It can be a bit more prominent in PV, but many people with ET can also experience this. There is an increased risk of bleeding in ET. It's not as common as problems with blood clotting, but some people experience nosebleeds, gum bleeding, heavy periods, or blood in the stool. Interestingly, people with very high platelet count are at higher risk of bleeding. And this seems almost counterintuitive because the platelets are the blood clotting cells. And we know that if you have very low platelets, people are at increased risk of bleeding. But in ET, very high platelet count, if there are too many of them, they don't function properly and can they can bind to this other protein in the blood called von Willebrand factor and lead to a condition we call acquired von Willebrand disease. Most commonly, this is something that runs in families, but in people with ET, there can be a similar bleeding problem due to reduction in these von Willebrand levels because of too many platelets. So we see higher risk of bleeding when the platelet count is extremely high. However, the primary concern we have in ET is with the risk of blood clots or thrombosis. And we do like to stratify people into higher or lower risk because that can impact what treatments we recommend. The risk stratification system is super simple. So low risk if you're 60 years or under and no previous blood clot, whereas high risk is anyone over the age of 60 or if they've had a previous thrombosis. So you can see this is not a very refined system, but it does seem to be the most reproducible for one of the most reproducible for increased risk for risk of blood clots, and it's been what's been used in the trials when they've tried different medications to try to reduce the risk. There is another risk score that has been proposed. It's called the IPSET thrombosis or International Prognostic Score for ET, but this is prognosis in terms of risk of thrombosis. And it incorporates, again, the main factors are the age over 60 and previous thrombosis being the main factors, but other factors that are also shown to increase risk of thrombosis are having cardiovascular risk factors. So this is high blood pressure, diabetes, high cholesterol, and also having the JAK2 V617F gene mutation is also a risk factor for thrombosis compared to ET patients who have the other mutations. And using this scoring system, they were able to divide people into 3 different risk categories. And you can see that, the risk of thrombosis in ET is definitely higher than the general population, but in absolute terms, it's in the low risk group, it's relatively low, and that it's 1.3% per year. And this is patients, of course, that are receiving therapy, that are receiving appropriate therapy for their ET. Moving on to the treatment for ET. So as I mentioned, the treatment for ET is primarily addressed at reducing the risk of thrombosis or blood clotting. So we divide people into this higher or lower risk groups and use that to tailor our treatment. So people in the lower risk group, we recommend aspirin as long as they don't have any issues with bleeding. And there may be an ultra low risk group of people where aspirin may not even be needed. In patients that we consider at higher risk of blood clots, we would recommend aspirin, but we would also recommend a medication because it's been shown that these medications can help so they work by lowering the blood counts, but they've also been shown to help reduce the risk of blood clotting. So sometimes it can be helpful to look at the data. When your physician is recommending that you take a medication, it can be helpful to look and see what's the data behind that. Why is that recommended? So one of the most commonly recommended medications for patients with ET considered at higher risk of thrombosis is hydroxyurea. So this is a medication that suppresses the bone marrow production of all of the blood counts, so the white, the red, and the platelets, and it's used in polycythemia vera and sometimes myelofibrosis as well. Back in 1995, there was a clinical trial published in the New England Journal of Medicine. And at that time, they took this was all people considered at higher risk of thrombosis with ET. Half the patients received hydroxyurea and half didn't. And this is the thrombosis-free survival. So you can see in the hydroxyurea arm, most people didn't have a blood clot. So it's like about 95% of people did not have a blood clot. Whereas in the control arm, it was much lower. So it was in the range of 70-75%. So there were many more blood clotting events or thrombotic events in the control arm. And so this was the pivotal study that led to the recommendation of the use of hydroxyurea to prevent blood clots in patients with higher risk essential thrombocythemia. Now, not everyone can tolerate hydroxyurea. Some people do have concerns about side effects of hydroxyurea. So there are other medications. One that was previously used quite commonly is called anagrelide, and it is still available as a second-line treatment. Anagrelide also works to reduce the risk of blood clots in higher risk patients, but it's not quite as good as hydroxyurea. So this was a trial that compared hydroxyurea to anagrelide, and the anagrelide was somewhat better than, the hydroxyurea was somewhat better than the anagrelide at reducing blood clots. Other subsequent trials have shown perhaps more similar responses, but based on this data, this is what has led to the recommendation of hydroxyurea as the initial therapy. The third treatment that is sometimes used in ET when medications are needed is interferon, and I'll talk a bit more in more detail about interferon in the polycythemia vera section, as there's more robust data for interferon in polycythemia vera. Okay, so the next disease I'm going to talk about is polycythemia vera. So this being where patients generally have high hemoglobin or hematocrit and may also have high platelets or high white blood cell. Clinical manifestations of PV, there's a lot of overlap with ET. So it's really the same 3 categories. So symptom management, trying to prevent thrombosis, which again is a major concern in polycythemia vera, and reduce risk of bleeding. And then also monitoring for this risk of progression to myelofibrosis. There is a significant overlap in the symptoms people experience with polycythemia vera compared to essential thrombocythemia or myelofibrosis, but different symptoms can be more prominent in the different disease subtypes. So in all three, we see fatigue, but this aquagenic pruritus or itchiness with water exposure is most prominent in polycythemia vera, but also can be seen in the other conditions. And then other symptoms such as night sweats, bone pain, fevers, weight loss, and discomfort from the enlarged spleen can be seen in all. The treatment of polycythemia vera, again, is based on risk stratification for risk of thrombosis, because the primary goal of therapy is to reduce risk of thrombosis. And you'll recognize, again, the same rather straightforward risk stratification system, looking at age greater than 60 or prior thrombosis being at high risk. For all patients with polycythemia vera and with ET, it is really important to make sure that all the traditional cardiovascular risk factors are monitored and addressed. So this involves blood pressure checks, checking cholesterol, screening for diabetes at age-appropriate times, and treating any of these risk factors that may come up. In polycythemia vera, we have good data to say that low-dose aspirin definitely does reduce the risk of cardiovascular events, and everyone with polycythemia should be taking low-dose aspirin unless they have a contraindication or high risk of bleeding. The other point that's very important in polycythemia vera is to keep the hematocrit under 45%. And there are different ways that we can do this. So we can do this with phlebotomy or with medications, but we know that keeping this hematocrit below 45 is important to reduce the risk of blood clotting. So in lower risk patients, we would often use phlebotomy, and in higher risk patients, we feel that using medication provides increased risk reduction for thrombotic events. So the times we would think about medications is if people are at higher risk of thrombosis, or if they had difficulty tolerating the phlebotomy, or had signs that the disease was progressing despite using phlebotomy. And I'll talk in more detail about the medications we can use, but you see there is some overlap with ET in that the first-line medications would be hydroxyurea and interferon, and subsequent medications could also include ruxolitinib, which is a JAK inhibitor. So we know that keeping the hematocrit under 45%, either with phlebotomy or medications, is really important in polycythemia vera to reduce the risk of blood clots, again, from another clinical trial. So in this trial, they randomized half the people to have a target hematocrit of less than 50%, and the other half to have a target of less than 45%. And you can see that the risk of blood clotting was, so these lines go down when people have a blood clot, the risk of blood clotting, this is death actually from cardiovascular events, and this is any cardiovascular event, the risk was much lower in the people where the hematocrit was better controlled. So this has led to this recommendation and consensus in the medical community that the appropriate target hematocrit is less than 0.45. In lower risk patients, we can achieve this with phlebotomy. So phlebotomy is the bloodletting, and the advantage is that this leads to immediate reduction of the hematocrit. Most people tolerate it well, and you don't need to take a medication, which certainly has some advantages. The disadvantage is the inconvenience of having to go into the hospital for these appointments. The phlebotomy or bloodletting, unfortunately, does not control or reduce the white blood or the platelet count. It can lead to low iron levels over time, which can lead to exacerbation of fatigue. And it's not felt to be as effective as medications in reducing the risk of blood clots in people who are at high risk, so in this higher risk group of people. Hydroxyurea is the most commonly used medication to treat polycythemia vera in Canada when medication is needed. It's well tolerated for many patients. It's an oral tablet. It's good at reducing the white blood, the hematocrit, and the platelets, so it brings all of the blood down. And for some people, can also reduce the spleen size and improve the symptoms. Side effects include mouth sores, ulcers of the leg, rarely a febrile or feverish reaction, some skin changes, and nausea. And there is some concern that long-term there may be some increased risk of skin cancers, not the melanoma, but the squamous cell or basal cell, which would have to be removed. And there's some controversy about the risk of leukemia with hydroxyurea, in that historically some hematologists have felt maybe there's a slightly increased risk, although some more recent larger population studies haven't confirmed that, but it does remain a controversial area. What I always tell people is that if there is an increased risk, it's very small, and it would be more than offset by the reduced risk of heart attack and stroke. Another medication that has been around for a while but is now becoming better studied is interferon. Interferon is a synthetic version of a natural substance in the body. It is given by an injection under the skin at different frequencies depending on the product. There are multiple different types of interferon. The original version was just called interferon, and it has to be given multiple times a week. They then formulated some longer acting versions, including one called Pegasus. So this is an interferon alpha 2A. This is the pegylated version that's available in Canada. It's given once a week as an injection. And then there's a new form of interferon called Ropeg interferon, which is slightly different. It's an alpha 2B. And this medication is approved for the treatment of polycythemia vera in Europe, but is not yet approved in North America, and it's currently not available in Canada. The interferon medications are quite expensive, and it is variable depending on the province as to whether they are covered or paid for by the government, and which type is covered, and when it is covered, which type is covered. So there are definitely issues with access to these medications in Canada. And it's also important to know that at present, it is what they call an off-label use, in that Pegasus has not been approved by Health Canada for treatment of polycythemia vera. It's actually approved for treatment of hepatitis C. So completely different condition, but it's used off-label for the treatment of polycythemia vera. There are different side effects with the interferons. In general, the Pegasus and Ropeg have less side effects than the regular interferon, but still do have side effects. The side effects include myalgia, so painful sore muscles and flu-like symptoms, changes in the mood, to the point where people have a history of depression. It's recommended not to take this medication because it can cause a recurrence. And some people note irritability and anger. It can cause issues with the thyroid, the liver, skin rashes, and some autoimmune effects. So a different sort of set of symptoms. And these medications have been around for a long time, and there's always been a lot of promise with them. But now the good news is there have been some more recent comprehensive studies, so we have a better idea as to what to expect with these medications. So this is my summary. Now there's a lot of nuances to this, and different studies show slightly different results, but I can confidently say that interferon is non-inferior to hydroxyurea. So there was a big study of Ropeg versus hydroxyurea. It was designed to show that Ropeg was no worse than hydroxyurea, and it proved that. So it's non-inferior. We also know that interferon can reduce the JAK2 allele burden, so the amount of this abnormal JAK2, and can lead to improvements in the bone marrow in some, but not all patients. There are some people who've taken interferon for a long period of time and then stop it, who can have a sustained response or improvement in their blood counts. Again, the follow-up needs to be longer to see how long this will last. There had been concerns, and there still are, about the tolerability of interferon. The more recent studies show that the side effects are definitely different, but at least in clinical trials were manageable, and most people there wasn't a higher discontinuation rate than hydroxyurea. When we think about why we're giving the medication, we're really primarily trying to prevent thrombosis. Interferon, there was no clear difference in rate of thrombosis compared to hydroxyurea, so it seemed, as far as we can tell, to work equally well, but the studies weren't designed to assess this or long enough to assess this. So there continues to be some promise with interferon. The hope that some of these improvements in the bone marrow can lead to decreased risk of myelofibrosis and improved long-term outcomes in terms of the risk of progression to myelofibrosis and leukemia, but we don't really have the data on that yet, and it's hard to get that data because fortunately so many people with PV do well and never progress, and when there is progression it can take 20 years. So you can imagine that this would have to be a very long study to be able to demonstrate the endpoints that we're really interested in. Finally, the other medication that is available in Canada for polycythemia vera is ruxolitinib. So I will talk more about this with myelofibrosis, but this is a tablet, a pill that is a JAK2 inhibitor. So it inhibits that overactive JAK pathway. It is approved and usually funded for people who are intolerant or resistant to hydroxyurea, so we have to try hydroxyurea first. What it's really good for is controlling symptoms and reducing spleen size. It also does control the blood count. So for a select group of people who can't tolerate or are resistant to hydroxyurea, ruxolitinib can also be a good option. All right, shifting gears to the last part of the talk, and this is on myelofibrosis. So recalling this can be the initial diagnosis of primary myelofibrosis or can evolve from ET or PV. So symptoms are a significant concern in myelofibrosis. In general, it's all of the same symptoms that can be seen in all of the myeloproliferative neoplasms, but can be more profound or pronounced in myelofibrosis, especially the fatigue. And the splenomegaly, enlarged spleen, is more common in myelofibrosis and can be more substantial or significant. People are also at higher risk of having weight loss, so losing weight for no reason, and the sweating at night. With myelofibrosis, although we still do worry about thrombosis, the shift in the focus is more to managing the symptoms, the splenomegaly, and then concern about the disease progressing to leukemia, which does happen over time in about a third of patients. And there can also be progression of the symptoms and issues with myelofibrosis without leukemia and other complications. But that being said, there is a wide variety in the clinical presentations with myelofibrosis. So I have some people in my practice who've had myelofibrosis for 20 years and hardly have any symptoms at all, and the disease has remained really, really stable, where I have other people where they run into trouble and complications much sooner. So it's really important with myelofibrosis to try to figure out where someone is on the spectrum of disease. Do they have disease that is going to be just fine for 10, 15 years, or do they have disease that's going to cause issues and health issues sooner? To try to sort this out, there are a number of prognostic scoring systems we use for myelofibrosis, and there's a large assortment of them. Some of the main systems use pretty simple, readily available factors. So age, whether you have these symptoms of fever, night sweats, and weight loss, and the blood counts. This should say leukocyte count greater than 25. So there's a number of sort of common, readily available factors that we can use to try to give an idea as to whether someone's in the lower risk or the higher risk group. There are also new factors that are available with additional molecular testing. So to diagnose myelofibrosis, you would need to have a bone marrow biopsy performed, which shows the features of myelofibrosis on the bone marrow. And at the same time, it's possible to take samples for additional genetic testing, looking for other mutations in addition to those driver mutations, but other mutations that can be seen in myelofibrosis that can impact prognosis. So they call them high molecular risk mutations, and this is a list of some of them. And having one of these mutations can increase the risk of the disease progressing, so make it into a higher risk disease. We also know that one of these having a CALR type, there's a type 1 and type 2 of CALR. Having the CALR type 1 mutation is a positive thing. So if you don't have it, then maybe at a bit higher risk. So there are a number of factors that we can kind of put together to try to determine if someone's in a lower risk or higher risk category. So the treatment, there are a number of different treatment guidelines for myelofibrosis. This is the ESMO one, but there's similar guidelines in the United States and different and the European guidelines. So we would use one of these prognostic scores, calculate a prognostic score, decide if higher or lower risk. If lower risk and no symptoms, then it's safe to just observe people and you may not need treatment right away. If there are symptoms, then depending on what the symptoms are, we can try treatment for the symptoms that occur, and one of the medications we commonly use is ruxolitinib, this JAK inhibitor. In people with higher risk disease, we do want to think if they're eligible for an allogeneic stem cell transplant, because this is the only curative therapy that we have. If the person is eligible, we would go that way. If they're not eligible, then we would use ruxolitinib and other medications to treat the symptoms people are having. So I'll talk briefly about transplant in myelofibrosis. So it is the only curative therapy, and how it works is we give a dose of chemotherapy to try to reduce or eliminate the myelofibrosis, and then we would infuse cells from a donor. So it would have to be a matched sibling or an unrelated donor. And we would think about this in patients with higher risk disease. The reason we don't do it in everyone is that there is a significant risk of dying or having serious complications from the transplant itself. So the things that we would consider, first of all, is does someone have a donor? Because if you don't have a matched donor, it's not possible. How healthy someone is otherwise. So a person who has more comorbidities or other health issues would be at higher risk of complication or dying from the transplant itself. And then we want to know what the prognosis is for the myelofibrosis, because if you have low risk disease, it wouldn't be worth it to take the risk of complications with the transplant. So basically with transplant, we're trading a risk of upfront or immediate complications and potentially death for the potential of an improved long-term outcome. So it can be quite a difficult decision in some cases, and of course would involve consultation with a transplant specialist. Most people, though, aren't eligible for transplant, either because they have lower risk disease and it's not the right thing to do, or because of comorbidities, especially because the median age of diagnosis with myelofibrosis is about 65. So a lot of cases we're looking at other options for managing symptoms. Many people with myelofibrosis have anemia or low hemoglobin, and we can manage this with red cell transfusions, or there are some medications we can try, such as Eprex or erythropoietin or danazol, which is a tablet, and they, depending on the situation, can work 30 to 50% of the time with some improvement. Some people with myelofibrosis can have low platelet counts, which can lead to bleeding. And again, we can treat that with transfusions or try medications, but it doesn't always work. The other group of symptoms relates to the enlargement of the spleen and the constitutional symptoms, so the fevers and night sweats. And the best medication for this is the JAK inhibitors, and the one that we use first is ruxolitinib. So ruxolitinib is an inhibitor of JAK2. It also inhibits JAK1. It's a tablet that's taken twice a day. The study that what we know about ruxolitinib from its original clinical trials is that it's very good at reducing spleen volume. So these are the green lines are people who took the ruxolitinib, and you can see each line represents a patient, and almost everyone had some improvement in their spleen size, with 42% having what we would consider a significant reduction of 35% of the splenic volume. Whereas in the placebo or control arm, most people actually had increase in their spleen size over time, although a few did have some decrease. Ruxolitinib is also really good at controlling symptoms for some people, not for everyone. Again, from that trial, about half of people had a very significant reduction in their symptoms by at least 50%, whereas in the placebo arm, that was rarely happening. However, there are some side effects, and what we know with ruxolitinib is it can cause the platelets to go lower, which can be problematic because a lot of people with myelofibrosis have low platelets to begin with, and it can also cause the hemoglobin to go low. So the green line is the ruxolitinib arm, can also cause the hemoglobin to go low, although it does tend to improve out at 6 months. So it goes lowest at 3 months and then improves out at 6 months. And both the impact on the platelet count and the hemoglobin depend on the dose. So at higher doses, it will cause further lowering of platelets and hemoglobin, but it also is more effective at higher doses for controlling spleen size in particular. So it does end up being a balance between wanting to have enough of the medication to control the spleen and the symptoms, but not too much that it causes the platelets to go too low. Hemoglobin, at times we need to give blood transfusions to get people through this low period here at about 3 weeks, but fortunately there can often be some subsequent improvement. Other side effects include an increased risk of shingles. So I do recommend that people get the shingles vaccine prior to starting ruxolitinib. We don't know for sure how effective it is, but as a precaution, there can be some increased risk of skin cancer. So again, it's the basal cell and squamous cell, not the melanoma, particularly in people who've had taken hydroxyurea before. I mentioned the low hemoglobin, low platelets, and then some increased risk of infection. So ruxolitinib can be a really helpful medication for many people, but unfortunately over time, in some people, it can start to lose its effect. So this is looking at people who had a good response in their spleen, where the spleen improved in the study, but over a period of 3 years, so 3 years is about here, about half of people unfortunately lost that spleen response. So it is a concern that over time, some of the responses to ruxolitinib are not sustained as long as we may like. And in the Canadian MPN Group, we looked at defining some of these loss of responses. So there's different ways that people can progress on ruxolitinib, can involve losing the spleen response, having more problems with anemia or low platelet count. So in these situations, if there's a loss of response, for the spleen, we would want to try to increase the dose of ruxolitinib if we can, whereas if the problem is low blood counts, then we may try to reduce the dose. So the first step is just trying some dose modifications of the ruxolitinib to see if that helps. But if that isn't helpful, then the good news is that we now have another JAK inhibitor that's available in Canada. So it's approved by Health Canada and it's available free of charge on a compassionate access program from the pharmaceutical company at this time. So it's a different JAK inhibitor. It's called fedratinib, or its trade name is Inrebic. It's a little different than ruxolitinib, whereas ruxolitinib inhibits JAK1 and 2. Fedratinib is more specific for JAK2 and also inhibits this protein called FLT3. So what we know about fedratinib is in people who were either resistant or intolerant to ruxolitinib and then received fedratinib, the response rates in terms of splenic reduction were about 30% in terms of having this very significant splenic reduction, although most people had some improvement in their spleen. And you see similar numbers for symptom responses. So again, in people resistant or intolerant to ruxolitinib, about 30% had a significant improvement in their symptoms on fedratinib. It does have side effects, and the side effects are different than ruxolitinib. So the nausea, vomiting, and diarrhea is more prominent with fedratinib, and many people do need to, it can be controlled, but people might need to take medication. So an anti-nausea medication or an anti-diarrhea medication. Like ruxolitinib, it can reduce the hemoglobin and platelets. And then there's a unique concern with fedratinib about a condition called Wernicke's encephalopathy, which is a neurological condition with confusion. And outside of fedratinib, where we see it most is in people who have history of alcohol abuse and poor nutritional status with low thiamine levels, but it's still a relatively rare condition. In some of the early clinical trials of fedratinib, this was seen as an unexpected finding, and this actually led to the discontinuation of clinical trials for fedratinib years ago. Subsequently, they've done more studies to show it was people who were taking a higher dose and had some other risk factors for nutritional insufficiency that were likely led to the symptoms, and some of the cases weren't really Wernicke's. But in any case, we're now giving the fedratinib at a lower dose and monitoring thiamine levels very carefully to ensure that because we feel this will reduce the risk of it happening. And it hasn't been fortunately has not been reported subsequently since the medication's been available in the United States commercially with taking these extra precautions. There are also some treatments that are coming in the future. So for myelofibrosis, there are a number of other JAK inhibitors that are in development. There's one called, and these are in clinical trials, there's one called momelotinib, which is the only JAK inhibitor that can actually increase the hemoglobin in some people, but it has a side effect of peripheral neuropathy, so numbness, tingling, fingers and toes. There's one called pacritinib, which is less likely to lower the platelets, so it can be good for people with low platelets, again having some more diarrhea, nausea type side effects. The other strategy is to try to add medications to a JAK inhibitor, so taking ruxolitinib plus another medication. And this has been a bit challenging. I mean, in general, a lot of different combinations have been tried. In general, what we see is it can work a bit better, but there's more side effects, so it's kind of a trade-off. There is a new medication that's going to be trialed for anemia in combination with a JAK inhibitor called luspatercept, which has been approved now for people with thalassemia, so an inherited blood condition, and hopeful that that may help to improve hemoglobin in myelofibrosis. And some other medications in development and in clinical trials. So there's definitely more to come, and it's great to see that new medications are on their way, but also really exciting that we actually have a new medication, fedratinib, which is available now in Canada. So thank you all, and I'm happy to take any questions.
Thank you very much, Dr. Foltz, for sharing today. It is a great talk. Thank you so much. So it is now time for our question and answer period. And if you haven't already done so, I'd like to invite you to type in your question in the question box of your GoToWebinar panel. I will do my best to get through as many questions as possible, although if we do not get through all the questions, be rest assured that we will contact you offline after the webinar. So let's see here. Let's start with this one. Is there a different treatment approach that should be taken with younger people diagnosed with PV?
So yes, so the main with PV, the main goal that we're trying to accomplish with treatment is to reduce the risk of thrombosis. And so age is an important risk factor for thrombosis. So people who are younger, who haven't had a clot, are more likely to be in that lower risk group. And it would feel less strongly or that we would need to use a medication. So often in younger people, we're able to safely use phlebotomy treatment as opposed to using a cytoreductive therapy. In people with PV, younger people who have had a blood clot, the age does enter into the considerations as to which treatment to choose. So many physicians would favor the use of interferon over hydroxyurea if it was available in a very young person, because again, hoping to have some added benefit for improvement in the bone marrow, which would be more important in someone who was younger and was going to have a longer duration of time with the disease. We also know that interferon is safe in pregnancy, whereas we wouldn't use hydroxyurea in pregnancy. So if there are issues about family planning, then that would impact the choice as well. So those would be the main considerations.
Thank you. Another question also concerning a younger diagnosis. Are there concerns with damage to the bone marrow with prolonged overproduction of blood cells from a relatively young age?
As far as we know, there isn't damage to the bone marrow from the cell overproduction. But when there are changes in the bone marrow from ET or PV to myelofibrosis over time, it is, and again, this is not well known, but it's most likely due to the bone marrow cells acquiring new mutations or changes that changes the behavior of the cells into creating the myelofibrosis or bone marrow scarring. So there can be changes in the bone marrow over time, but I don't think it's a direct result of the overproduction or increased production.
Thank you. Is there a genetic tie with MPNs? So this person was diagnosed as well as someone else in their family.
So most people who have MPNs don't have anyone else in the family who has an MPN. So that's the most common situation. But we do know that there are some families where people seem to be more prone to acquiring the mutational changes, especially in the JAK2 V617F gene mutation. So you wouldn't be, even in families where there's a strong family history, people are not born with that mutation, but there's something in their genetics that predisposes them to acquire it. And there are several different mechanisms of that have been identified in some families, but in other families, we don't know what the specific trigger is, but the answer is yes, there can be some families where it's more prone to. In those families, the next question that comes up is, how should we be testing other family members and how do we do that? In general, what we would suggest is family members who, are concerned can just have a blood counts done. And if their blood counts are normal, there would be no need for any intervention or treatment at that time. But it is something that family members may want to check every 5 years or so, because the MPN develops later in life and can occur in the future even if it wasn't there previously. But even in people who do have strong family histories, it's not that everyone gets it, it's just that it's more likely, so some people get it but others don't.
Thank you. For people who cannot tolerate aspirin, what are your thoughts on natural treatments for high platelets, such as ginger and turmeric?
So a lot of people do use those, use turmeric and ginger. We just don't really know. So I haven't seen any studies to know whether that is helpful or not. So it's really difficult to make a definitive recommendation. In terms of the conventional medical therapy, if people have trouble with bleeding, like stomach bleeding with ulcers with aspirin, then there is the medication clopidogrel or Plavix, which is an alternative medicine that we sometimes do use.
Thank you. When is splenectomy an option?
So splenectomy can be considered it's generally in people with myelofibrosis because for the most part, this large spleen is less of an issue in ET and PV or can be controlled with medications. In myelofibrosis, we would generally recommend a medication first, like ruxolitinib, usually ruxolitinib, the JAK inhibitor, because it can often be effective at controlling the spleen size and have other benefits for people as well. But if someone's in the situation where ruxolitinib doesn't work or isn't tolerated, then we can try another one like fedratinib or a clinical trial. But if none of those are an option, then we sometimes do consider removing the spleen. The times we would think about it is if the spleen was very enlarged and causing a lot of discomfort, making it difficult to eat or to eat large meals. The problem with removing the spleen is there is some risk of complications during the surgery. It's a medium-sized surgery, especially when the spleen is large. And the other issue is after the spleen is removed, people can get enlargement of the liver, and the liver can become quite large afterwards. So it is something that needs to be weighed out, but it is an option.
Thank you. I think we have time for one more question. Why isn't interferon used more often in low-risk ET patients, specifically for symptom management?
The data to support the use of interferon in low-risk ET patients is less. So we are getting more data on interferon. Most of the studies that have been done are in people with high-risk PV who have a reason for treatment in terms to reduce their risk of thrombosis, so over the age of 60 or previous thrombosis. So that's where we have the most robust data to show that it's equivalent to hydroxyurea. There's quite limited data there is some data in ET, but it's mostly in high-risk people. The data for people with low-risk ET is quite limited. We need to think about, what we're trying to achieve with that, and it absolutely can help with the symptoms in some people, so that is definitely a reason to consider it, keeping in mind the trade-off with the side effects of interferon. And then the other reason why some people think about it in early stage ET is hoping for the long-term benefits of bone marrow improvement. And we just don't really have robust data for that for low-risk people to know whether it's worthwhile taking that medication long-term for that outcome. The other reason why it is not as widely prescribed in Canada relates to funding issues because it would not be funded by most provincial governments for low-risk ET. So it would be, and there's variable funding from private insurance plans. So I definitely do prescribe interferon, but more commonly in the higher risk patients, mostly PV, but some patients with ET.
Thank you so much. Once again, thank you very much, Dr. Foltz, for being with us today and for sharing.
All right, thank you for having me.
So just a reminder for those of you, if we did not get to answer your questions, then we will do our best to reach out to you afterwards offline. Before we head off, I would like to thank Bristol Myers Squibb for helping to make today's webcast possible. And I would also like to remind everyone that we are here for you. Do not hesitate to contact the LLSC if you need more information or support. You can reach us by email at canadainfo@lls.org or toll free at 1-833-222-4884. Also, make sure to check out our website regularly to watch all past webcasts and to look out for the dates of our upcoming webcasts. For example, next Wednesday at 1 p.m. Eastern Time, we have our COVID-19 and vaccines webcast. So if you're interested, please visit our website. Last little note, there will be a short survey that will be sent out to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it really helps us to offer you the most valuable information in the near future. So thank you everyone for joining us today. Have a wonderful day and stay safe.